0.25 ml, 0.5 ml, a lot of controversies, and I believe Dr. Kashi and team is in for a challenging job ahead. Well, friends, for the session here today, we have got eminent faculty led by Dr. Kashi, Srinivas Kashi from Bangalore. Kashi sir was the founder, president of the respiratory chapter of Karnataka State Branch, and he was the vice president of National Respiratory Chapter right now from 19 to 21. And more importantly, known as a doyen on immunization aspect practice. He was a member of the ACVAP in right now 2021, and even the IAP Committee on Immunization in earlier days. He has contributed chapters in infectious disease, vaccines, and even many textbook of pediatrics for postgraduates. And he's a trainer in the science of vaccinology. The undisputed, the last opinion comes from Dr. Kashi many a time. And this is, of course, a renowned and popular speaker for most of the sessions across in the IAP forums. With Kashi sir, we have got another 4 experts who will be lending support to him and deliberating on issues which have been, will be something innovative, will be give us some new thoughts. We have got Dr. Arun Vathwa from Delhi, and he is a very senior pediatrician for practicing for over 29 years. Having had other chapters in IAP textbook of FAQs and IAP textbook of vaccinology, he has got a lot to offer for us in this session. And he has done courses in vaccinology conducted by NFID Washington and even the Child Health Foundation. And he has been a national trainer for the vaccine forums. We have got our seasoned academician from Hyderabad, Dr. Surendranath. He was the vice president of Central IAP in 2019, and he is the president-elect of Pediatric Academy of Telangana. He was always known across the country as the honorary secretary of Family Benefit Scheme of IAP in the 2017-20, and he is the EB member 2014-16, and as a past vice president of the Twin Cities branch, secretary of NNF, and more important known for his involvement in NRP as well as NNF, and he has been a regular faculty for most of the immunization forums across the country. Joining Dr. Vathwa and Dr. Surendra, we have got Dr. Sanjay Niranjan from Lucknow, a very seasoned, accomplished pediatrician. He is the present EB member, National Executive Board member, and he was the president of NNF Lucknow in 2018-19. President of the Lucknow branch, as well as in the IAP teaching forums. He was a national trainer of many IAP modules, and he was a joint secretary of UP State IAP in 2013. And sir has got lots of experience behind him to offer for us today. And we have another young, dynamic friend from Nagpur, Dr. Sanjay Marathe, joining us for the panel session. Dr. Sanjay Marathe was the organizing secretary of Pedicon 2018, the Nagpur Pedicon, and he was the chairman of the scientific committee, and we all know how well it went on the scientific sessions in Nagpur. And currently he is the director of the Marathe Childcare Hospital and the director of Kalais Pediatric and Neonatal Intensive Hospital. And he was the president of Maharashtra NNF way back in 2009-11 and president of IAP Nagpur, and is a ACVAP member from West Zone in 2022. So friends, that's a great team for us today here, led by Dr. Kashi, Dr. Vathwa from Arun Vathwa from Delhi, so Dr. Sanjay Niranjan from Lucknow, Dr. Surendranath from Hyderabad, and Dr. Sanjay Marathe from Nagpur. That's a pan-India great team for us deliberating on immunization issues today. And I believe we'll have a fantastic, exciting session in the next 1.5 hours, 90 minutes or more. I will invite Dr. Kashi sir to take over the proceedings for the scientific session. Dr. Kashi, please.
Thank you, Dr. Ramesh, for the very kind introduction. It's always a pleasure to talk to the audience from Kerala. Today's session is not going to have any theme. It's just a collection of different issues regarding vaccinations. We've had so many webinars in the past few months, especially on vaccinations. There may be some repetition of questions. I beg forgiveness if there are repetitions, but every time the same issue is discussed, there is always something new to talk about it. I'm very fortunate that I have a very, very esteemed panel who have been introduced, and any panel discussion depends not on the moderator but more on the panelists, and I'm sure that will lead to an excellent session today. So let's start. Now we come to a situation where a 9-month infant is brought to you for the vaccines. You notice that he has received only the bivalent oral polio and the pentavalent vaccines, no IPV at all. So my first question is, in today's scenario, how important is protection against type 2? And if you feel it is important, what will you do to rectify this anomaly? Dr. Sanjay Marathe, can you take this, please?
Yeah. Good evening, everybody, and it's a great pleasure for me to join such an eminent panel, headed absolutely by our teacher, Dr. Kasi sir. Good evening to all the audience who have joined for this panel. I think this is not a very uncommon situation to find an unprotected child. This situation was created because of the acute shortage of IPV created in 2016, when all over the world we joined the endgame polio program. And because of the acute shortage, subsequently we went for the risk mitigation strategy, and intradermal doses were given in the medical colleges, whereas the single dose at 40 weeks was given at the private practice. But many times it happens that the patient either is not affording are not offered this IPV dose at 14 weeks. And then there is no option because standalone IPV is not available for so many years. So now this child is 9 months old who is not protected against especially type 2 polio is definitely at a risk of following conditions. One CVDPV, though the risk is quite less because the risk was maximum in first 2 years, but if you see the mathematical model, the risk is still there up to 5 years. So this is one situation. If our country is polio free, that does not mean that the world is polio free. Our own neighboring friends, Pakistan and Afghanistan, they are having good number of wild polio viruses as well as good number of CVDPV from the various countries. I was reading yesterday that the Sudan is having outbreak of CVDPV too, and they are very closely monitoring. So another possibility of transportation of the either wild polio or CVDPV, because the world has become too small. And third, if we'll say an accidental leakage from the research laboratories that the wild polio virus is like or a type 2 polio virus is like. Another important thing will be and malicious intention of you can say biological war from our neighboring country where they can introduce wild polio virus to our country. So all these things are possible for this child who is unprotected. Now, what are the options? So I must give him some protection. So I will talk with the parents. I will say your child is definitely having some degree of risk, though it is quite less with CBDPV, which is not reported from our country.
Hello.
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 Sir, am I audible?
Yeah.
So I will offer him couple of things. I will tell him that your child is not protected against type 2, which on priority I would like to give you some kind of an protection, at least one dose if it is possible. So the nearest one is the booster which I can give you after the age of 1 year, and I will select a combination which contains IPV and will try to protect him at least with the one dose. If it is not, if I'm lucky enough, I will keep a track of this patient, and if I'm lucky enough to get an standalone IPV, I would like to give him at least 2 doses, 8 weeks apart, which gives you adequate protection, followed by boosters which are otherwise there.
Okay, Dr. Sanjay.
Yeah.
Will you consider giving an extra dose of a DPT IPV containing vaccine to this
Absolutely.
child?
I was about to come to the same third option.
Yeah.
I said I will talk to the parents. I said if I give an additional dose, unfortunately, I will have to offer him a combination IPV vaccine. I may give him at least one dose which contains IPV, but at the same time, I will explain him that your child will have no significant problems except some local reaction. What I will give it now, the availability of tetraxine, which is DTAP plus IPV, will be a good option, which I can offer to him, which gives him at least one dose. So with one dose, his sensitization is almost 100%, though this seroconversion is to the tune of 63% from the Cuban study, or could be even more than that if I'm giving at the age of 9 years. So I have these three options available. I will certainly offer all to them, and depending upon the affordability and the availability of the vaccine, these three options will be given to the child and the parents.
Okay.
You have got any slide share?
Are my slides not seen now?
No,
No.
sir.
No.
No, you have not shared it.
No, I just shared it. Now,
Yeah,
can you
now.
see?
Yes.
Wonderful. So I think it is important that we should have protection against type 2. I think giving an extra dose of DPT containing vaccine may be a little extreme at this stage, but what Sanjay suggested that you bring forward the 18 months
First
booster. You can give it as early as 6 months after the last dose. So you can give it at the end of the first year or the beginning of the second year so that some protection against type 2 is there. I think it's a very common situation. We should know how to handle it. Any comments, Dr. Surendranath?
That is the best option, sir. As early as possible, we should give some IPV combination.
Okay, because the DPT reactogenicity increases with the number of doses, and generally not more than 7 doses are recommended in the first 10 years of life. So you have to keep that in mind before you consider an extra dose. Now let's come to another situation, very common. A doctor has sustained occupational exposure to hepatitis B. He had received 3 doses of hepatitis B almost 20 years back. And for some reason, an antibody titer was done about 8 years ago, and it showed a titer of 20 microinternational units per ml. But today, when they test it, it is negative on the day of exposure. So what is the optimum thing to do? Will you give a booster of hepatitis B now? Will you give both hepatitis B and immunoglobulin, or you feel there's nothing to be done? Dr. Sanjay Niranjan, can you take this?
Yeah, of course. I'm here.
Dr. Sanjay Niranjan is not. Is Dr. Sanjay Niranjan not on? He was there on the.
Is there Dr. Sanjay? Are you?
Okay, Dr. Wadhwa, can you take it? Arun?
Yeah. So this doctor, he has fortunately got a test done, and it was proven that he responded to it. If he hadn't got it done, then we were in the soup. But now once he's got it done, he has antibodies once demonstrated. So no intervention needs to be given because the memory cells will respond and he'll produce a good antibody response.
Wonderful.
Nothing needs.
So nothing needs to be done. Suppose you did not have the antibody titers. How will your approach change then?
So then it was a problem. Then we would have to give him IVIG plus hepatitis B both, and then check again after 6 weeks. And suppose he has a good response, then it's fine. If he doesn't have a response, then we have to give 3 doses, and IVIG was given first day.
So I think this chart gives you a very clear picture of what you should do. Since the source is HBAG positive and he's a known responder, you don't have to do anything. If you do not know the response, in that case, you have 2 options. Either you check for the response now. You can wait for a few hours and ascertain the response. If the response is inadequate, that is less than 10 MIU, then you need to give, as Dr. Arun mentioned, 1 dose of the immunoglobulin, and you have the option of either restarting the series or you give 1 dose, check the antibody titers, and if negative, you complete the schedule. These are the 2 options available. I think this is a pretty straightforward situation. Now let's come to another situation. I think diphtheria is on the rise everywhere. I think a lot of cases from Malappuram district. We have a lot from Karnataka, almost about 36 cases from Bangalore, which have been reported. So a pediatrician is treating a case of diphtheria. He has received his last booster at DPT at 5 years, and he doesn't know whether he has taken any boosters after that. He is presently 33. In this situation, what are the things to be done? One, does he require any investigations? Does he require any treatment? Does he require any vaccines? All these three aspects I would like to be answered. Dr. Arun, I think you can take over again.
Yeah, so actually this question is similar to the previous one. The only difference is hepatitis B had a long incubation period. So we
Yes.
could wait for the body to respond, but diphtheria doesn't have a long incubation period. We want immediate response. And since he had the last dose at 5 years, most likely may not have antibodies. So we have to give him some form of D containing vaccine, could be TD or TDAP, whatever is available immediately. And then he has to be started on some kind of prophylaxis like erythromycin for 7 to 10 days.
Okay. Now, I think you should also
And of
get
course,
a
the culture
swab.
should be done first day.
Yes, you
and
have
then
to
the
get a
last
throat swab
at the
done.
last also, yeah.
You should get it done at the beginning and after you finish the chemoprophylaxis.
Yes, for
Now,
both.
suppose he's in the incubation period. Is there any harm in giving the vaccine like Tdap, or it doesn't matter?
Incubation period means he's been
Suppose he has already got infected.
Yeah.
Still, will you give Tdap now, or will you
Yes,
wait?
yes. No, I'll give it.
Fine. So basically, incubation period of any illness is not a contraindication for giving the vaccine. An acute illness, yes, it's a precaution, but incubation period is not a precaution. You can certainly give the vaccines. Anything to add, Dr. Sanjay or Dr. Marathe or Surendranath? Anything you would like to add on this?
Definitely after doing
Give vaccine and followed by the prophylaxis.
Wonderful. I think these are all standard protocols.
Yeah.
I brought up this case because this is becoming common situations. And
now the
unless-
recommendation is TDAP is better, sir. Instead of
Exactly. Tdap would be a better, at least one dose. And I think now even the American Academy of Pediatrics has formed a more relaxed attitude towards Tdap. It's no longer a single dose. Wherever a TD is to be given, you can always give a Tdap instead of a TD. That is what the latest 2019 recommendations have stated. Okay. So these are the things you look for: appearance of the disease symptoms from 7 days from the last contact. You do a throat swab, you give oral erythromycin for about 7 to 10 days, and you give a booster dose of an appropriate diphtheria containing vaccine. This is the protocol in this particular situation. Okay. Now let's come to another child. This is a 4-year kid on treatment for nephrotic syndrome. He has completed 4 weeks of full dose steroids at 2 milligram per kilogram and is now on 1.5 milligram per kilogram alternate days for the past 10 days. He unfortunately got exposed to varicella just yesterday, and he has not received any varicella vaccine. Now, Dr. Surendranath, first question, is this child at risk for severe varicella and complications?
this child is definitely at risk for severe varicella complications, sir, because he is under immunosuppression because of the steroids. As it has been told that 2 milligram per kg body weight, at least if it is more than 2 weeks continuously given, the child will be under immunosuppression. So the daily usage of 2 milligrams per kg per day, or if the child is more than 10 kg, 20 milligrams per kg per day, dose is a essential. I mean, it tells that a child is under immunosuppression. Now the child, if you want to vaccinate this child after giving a daily dose of
அப்படி சொன்னா நான் என்னடா பண்றது பரவாயில்ல அதுல ஒண்ணு இல்ல எனக்கு ஒன்னும் கோவம் இல்ல நான் எங்கேயும் போக
after
மாட்டேன்
stopping the steroids, we have to wait at least to give a live vaccine, in fact. But this child is since last 15 days, he is on alternate day steroids of 1.5 milligram. So he has not yet completed the 1 year period after stopping the steroids. That means
1 month. 1 month.
Yeah, 1 month. 1 month period is not yet over. That means he is still under immunosuppression. We are not supposed to give any live vaccine at that time.
Okay, so you would rather not give the varicella vaccine, right?
At that moment, it is difficult, sir, to give because the child has not completed 1 month period of.
ஆர்குமெண்ட் இல்லனாலும் நல்லா
So,
இருக்கும் இந்த மாதிரி கொஞ்சம் இருந்தா தான் காசு
other option is to give varicella immunoglobulin. If it is available, we can give varicella immunoglobulin.
Okay, so basically, I think here the message that has to go with this case is: 1, varicella is devastating in an immunosuppressed child. The effect of full dose immunosuppression last for at least 1 month after stopping the full dose steroid therapy. See, this child is now on alternate days, but still it's not even 1 month since the full dose has been stopped. So this child is still immunosuppressed. And if he's immunosuppressed, no live vaccines, you have to give alternatively, and the alternatives have just been projected. If it's available, you give the immunoglobulin, varicella specific immunoglobulin, or you give IV IG 400, or even if that is not available, then you start on acyclovir. You start it 7 days after exposure, because that is the median incubation period. And you give for another 7 days because that is the period of viral replication. So you need to start after 7 days and give it for another 7 days. I think these are the messages that I want to convey with this particular case. Any comments from the other panelists?
No, perfectly fine.
Okay. Now, a 6-year child on maintenance phase of chemotherapy for acute lymphatic leukemia comes in contact with a varicella. Okay, please mark maintenance phase of acute lymphatic leukemia. Can you administer the varicella vaccine? Dr. Sanjay, I would like to do the case. Dr. Sanjay handles a lot of pediatric oncology patients. So I would like him to answer this.
The question is very important. As we know that the patients of ALL they are extremely prone to get a very fulminant type of varicella infection. And the new recommendations have come especially for the varicella vaccination.
Hello?
And he is in remission for more than 1 year. If his lymphocyte count at that time is more than 700, and if the platelet is more than 1 lakh, if this is the situation, you can certainly give varicella vaccine to these patients.
Wonderful.
So this is a very unique situation where a live vaccine can be given, because considering the high risk of very fulminant varicella, this has a new recommendation has come, and you have to just follow these three things: lymphocyte count more than 700, platelet count more than 1 lakh, and he should be in or child should be in remission for at least 1 year from the chemo.
And something about stopping the chemotherapy before and after vaccine?
Yeah, and 7 days before and 7 days after the chemotherapy should be stopped. That is mandatory if you are giving the varicella. Otherwise, it will interfere.
Is there any risk in stopping the chemotherapy like this for 7 days, 14 days?
Sir, we'll have to weigh the two things, because if child has already received the chemotherapy subsequently and he is in the maintenance phase, we can certainly stop it for 7 days, because many times we have seen if the patient is severely febrile neutropenia or something like that.
Hello.
Yes, sir. A request from my side, please mute your devices. We are having a lot of disturbance. We are gifted to open for the open-ended session.
Dr. Sanjay has to unmute.
Dr. Sanjay, unmute.
I wanted to say, is it a good idea to do a CD?
Okay, sir.
Dr. Arun, you are muted. Please unmute yourself.
You have to unmute and talk, sir. Dr. Arun, sir.
Arun, unmute.
Oh, actually, the host has muted me, no, so I couldn't.
Yeah.
Now.
So what I was saying is, another good idea could be we can do a CD4 count and see the count, percentage of the count, and then decide. Rather than having
we have seen that the CD4 counts are normal in this situation because he's in the maintenance phase.
Yes.
That is the reason that it has been specifically mentioned that if he's in remission for more than 1 year.
Right. So you feel after 1 year the CD4 would be normal.
Yes.
So that is the reason that CD4 counts are not required.
Because the maintenance phase medications usually do not cause significant immunosuppression. Okay, now we go to the next aspect. Sorry. Now, after completion of chemotherapy, do you need to give any boosters, and when will you give the boosters? Dr. Sanjay, you can take the question, please. Sanjay Marathe.
Yeah. So this 6-year child who has completed the chemotherapy, we all must understand one thing: the disease itself has never suppressed the immune status and have demonstrated that basically chemotherapy or the radiotherapy which is given is making the patient immunocompromised. That is one. So I would like to know what is the pre-chemotherapy immunization status of a child.
Okay.
And that will depend on my post-chemotherapy immunization status. Considering that this child has received age-appropriate vaccines before the chemotherapy, the rule says the vaccination should restart after 6 months of completion of chemotherapy or radiotherapy. That is one. There are only 3 exceptions to this. One, varicella, we have already discussed. Second is the influenza vaccine. Sometimes the advocate, even the CDC says, even during the chemotherapy, you may give 2 doses of influenza, just the child from severe influenza. And third, hepatitis B, because lot many times we'll be giving blood and all that. So hepatitis B, where you'll have to give 4 doses, 0, 1, 2, 12. Sometimes you'll have to double the dose, like that. Here, apart from these 3, now the first vaccine after 6 months of completion of chemotherapy or radiotherapy will be first flu vaccine. As the child is 6 years old, if he has not received before, I will give 2 doses of inactivated influenza vaccine. Then from 6 months onward, I will give booster of DPT. If the child is less than 6 years, I can offer him DWTP or DATP. Secondly, I will give 1 booster of hepatitis B if previously immunized. I will give 1 booster of hepatitis A if he is previously immunized. Then I will give 1 dose of PCV13 and I will also give 1 dose of Hib. We should all remember that Hib is also recommended even if the child is more than 5 years. The MMR vaccine will be given after 2, if he is not previously immunized, I will have to give 2 doses. If he is already previously immunized, I will have to give 1 dose of MMR. Chickenpox, if I am not given during the situation which I have discussed, I will have to give 1 dose at least of booster of chickenpox with the vaccine.
Okay, so I think
far as at the same time, what we should remember, the sibling should continue to have a normal immunization as per the age. Only thing is that the sibling should not be given OPV and IPV should be preferred. And those who are taking care of this child must be protected against chickenpox, Tdap, and influenza. These are 3 important vaccines. If unfortunately the sibling is given OPV accidentally, then at least there should be no contact with the patient for at least 2 weeks. I think these are all important points to be covered. If the child is not protected, age-appropriate vaccines, then it will be a catch-up.
I think excellent, Dr. Sanjay. I think you spot it out exceedingly well. And I think the message should go that after completion of standard dose chemotherapy, a booster of all the vaccines are necessary because there is some amount of suppression of the memory cell response also with standard dose chemotherapy. Hence, a booster of all the vaccines are necessary, even if they have taken the boosters, age-appropriate boosters in the past. Thank you, Dr. Sanjay. Now, there are certain situations where very highly aggressive chemotherapy is used, like relapsed leukemia or involvement of testicular or CNS, etc. In such a case, do you think you have to restart vaccinations all over like after a transplant, or still can you get away with giving only the boosters? Dr. Sanjay.
No, sir. Sir, if the child has received high dose chemotherapy, it is considered as equivalent to a child with HSCT, hematopoietic stem cell.
Right.
So almost we'll have to start as if his immunization name.
Wonderful. I think
this
that is
the
another
basic difference between a standard dose and a high dose.
Yes, that is a very important message which is to be conveyed. Of course, we may not encounter such situations on a day-to-day basis, but I mean, with increasing number of transplant being done for leukemia all over our country, the day is not far off when such patients are going to come to a general pediatrician's clinic for vaccination. And we have to be conversant with these guidelines and protocols. Okay, now we come to the next question. Has Dr. Sanjay Nirupam back, or is he not there? Dr. Sanjay Nirupam?
He's back. He's back.
I could hear his voice just now.
Okay, wonderful. Now, a very common situation, or rather I would say not an unusual situation. You have administered the typhoid conjugate to a vaccine to a child. You have affixed the sticker on the immunization record. The parents are waiting mandatory 10 minutes outside. But 5 minutes later, the father comes inside, shows you the chart with the sticker and says this vaccine has expired 3 months back. Okay. I mean, Dr. Sanjay Nirupam, what will you do in this situation? Dr. Sanjay Nirupam?
Ranjan sir.
Niranjan.
Dr. Sanjay Niranjan?
Dr. Sanjay is not here, I think.
Is
But
not
just
here?
he was talking on
His
phone.
audio had some problems. He had made an exit and he has rejoined. Actually, he discussed with me.
But he's still not available. Okay.
Host has muted.
Yes, sir.
Yeah,
Balachandran.
host has
Has the host muted him?
Yeah, looks like.
I think
Bala.
can anyone call him and tell him to unmute himself?
No, he can't do it. No, he's writing that host is muted.
Oh,
He's
host has-
unmuted. He's unmuted.
He's unmuted. Dr. Sanjay Niranjan,
Yeah.
can we hear you?
Dr. Sanjay Niranjan sir.
No, I'm trying to unmute him.
Okay.
Just wait for a few seconds.
I'll call him. Otherwise.
Okay, it's all right. Dr. Surendranath, can you take this question?
Yes, sir. This situation of using expired vaccines do occur most of the times. I mean, not most of the time. I had one experience definitely with flu vaccine. So whenever you give an expired vaccine, I think you need not panic about the vaccine. Only the problem is the antigenicity of the vaccine may not be similar to the vaccine which is given before the expiry date.
Yes.
As skilled vaccines are concerned, you have to repeat the dose as and when you have noticed the that you have given an expired vaccine. Explain the parent that it is not going to do any harm, but we have to repeat the dose as early as possible, maybe on the same day or as early as possible you can do with that. Because typhoid conjugate vaccine is an inactivated vaccine, anytime we can repeat the dose and tell the father that need not worry, the second dose which we gave will take care of them. If you have given a live virus vaccine, for example, MMR or a varicella, if you give an expired vaccine, then also there should not be any problem to the patient. Only thing you have to repeat the dose of live virus vaccine at least after 4 weeks, because live virus vaccine, we do not know how much quantity of the live virus is existing in the expired vaccine.
Right.
Till 4 weeks and repeat the dose again. But explain the parents always that there is no problem with the expired vaccines, but you may have some problem technically, but you have to deal with it.
Thank you, Dr. Surendranath. I think here I would like to emphasize that if you accept that an error has occurred and you rectify that error, or at least offer to rectify that error and document it, you are not medically liable. Okay, so please document everything. That is extremely crucial. The father may get upset and walk out and say, I don't want any more vaccines, but it has to be recorded that you offered it. And in that case, no court of law will hold anything against you. The major thing to be emphasized is there is no harm in giving expired vaccines, and there is documentation both in the CDC website that these vaccines, expired vaccines, are not harmful. I think this is the message which I would like to convey to the audience.
Also probably tell them that the fever might be more when you're giving two typhoids. One you've given,
right?
Another one, even if it's expired, it will cause maybe a little fever, and both of them will cause more fever.
Okay, now we come to another situation. This is something that happened in my own clinic. This was a 7-year boy with a category 3 exposure to a stray dog. He presented late evening in the clinic. As usual, I did the wound hygiene. I infiltrated rabies immunoglobulin. I used that human preparation called Camarab, which was available at that time. And I gave the first dose of Rabipur at a different site. And as usual, I asked him to wait for 15 minutes following the immunization. 15 minutes, just when it was about to go, he developed rashes. He started sweating, cough and wheezing. Classical anaphylaxis. Immediately did everything, adrenaline, shifted him, gave some IV fluids, kept him for a day, and he was discharged. Though he recovered quickly, still it's mandatory that he should be kept for 24 hours because you can get secondary or late onset symptoms as well. So he was kept for 24 hours and he was fine. Now we know that anaphylaxis to a previous dose of a vaccine is a contraindication for further dose of the same vaccine. This is general principle. Now, is it applicable in this situation? If it is applicable, what do you do next? If it is not applicable, so what do you next? I would like Dr. Arun Wadhwa to discuss this.
So actually, it's a little tricky situation. Anaphylaxis is there and there's contraindication, but with rabies, we have to give the vaccine because rabies is a deadly disease and we can't say, okay, something else we'll do, but we have to give the vaccine. First of all, I think we should think which one of the two would have caused human immunoglobulin or the vaccine. And actually, anaphylaxis can be caused by anything. Could be the vaccine itself, could be the excipients. Excipients could be thimerosal, could be MSG, could be egg protein, could be gelatin. So we'll have to go and look into what all the vaccines have. So we can go in order of commonness. The gelatin would be the most common, maybe thimerosal and MSG later. And if Rabipur has gelatin in it, then we have to be most likely gelatin is the cause. So I think we'll have to stop giving Rabipur, but we can't do that. So what we'll do is we'll admit him. Next dose, we'll admit him in the hospital. Start giving with less doses, 0.01 ml, then 0.1 ml, then 0.2 ml, and then gradually increase. Every 15 minutes, half an hour, we can give it. And best done in a hospital which has ICU facilities. So we'll have to do it very carefully, and it has to be done in a big hospital. Neomycin could also be caused rarely.
Wonderful. So basically, I just want you to go to this particular slide, which shows the potential allergens in vaccines. Now, if you look at all the list and apply to this particular situation, antibiotics, thimerosal, aluminum salts, formaldehyde. None of these are there in this vaccine. Of course, neomycin. Now, could it be egg proteins? This child is an egg consumer, so unlikely. Could it be latex? We don't know. The rubber stopper contains latex.
Actually, latex is also very less often seen,
Yes,
not very common.
Yes. So that boils down to gelatin, which is there in this particular vaccine.
Actually.
Yes. And in fact, this is a study done from Japan, where they studied all the anaphylaxis following vaccines. And what they found is the more severe the reaction, more possibly that is due to gelatin. In fact, in those who presented with anaphylaxis, 41 out of 44 had anti-IgE, gelatin IgE. Those who developed mild also had a large number, and those who developed just some rashes also had almost 80% had. So basically, I think in all of them, gelatin is the main cause.
MMR is the same thing.
Yes, very unlikely that it is the antigen per se which is causing the anaphylaxis. And as Dr. Yes, anyone?
Yeah, Kashi sir and Dr. Sanjay. So
Yeah,
in this situation, can we give intradermal remaining doses? If you go with the position paper 2018, they say if you are following intramuscular schedule, and if you would like to switch it over to the intradermal, you can do that. And
yes,
not a bad idea.
So can
it's
we
not a bad idea, but you are giving the antigen, and you should remember
so
that
we have to be very careful, but the amount of antigen given will be less.
In anaphylaxis, it is not the quantity of the antigen, it is just the presence of antigen which can cause anaphylaxis. It's the quantity is not important. Once it is above a certain level, it is not important. So I think whether you give intradermal or intramuscular, it doesn't matter. But the main thing is you have to give it in a very, there is a particular protocol which is followed for this, which is available in all the standard books, and interested persons can go through it. So I think this was a really scary situation. I mean, for one reason is an anaphylaxis in a clinic late at 8 o'clock at night is, I think, cuts your life by at least 5 years. I think that is the amount of stress that you have. And of course, what to deal with it. And as Dr. Arun said, in a hospital with ICU facilities, that child has to be managed further.
I've had one anaphylaxis with my patient, fortunately, and it was with veripet, chickenpox. One doesn't expect. But fortunately for me, what happened was that the child had this anaphylaxis not with me. He was taking vaccines with me. He had gone to Canada to visit his friends, relatives there. And there he was given veripet. And then in the hospital, he was given, fortunately. And then they did all the testing and they found that small amounts of human globulin was there, which was probably causing the anaphylaxis. So veripet I checked that.
One more message to go is you have to be ready to handle it.
Adrenaline.
At least adrenaline, which is not
Non-expired.
expired,
Yeah.
and an oxygen cylinder is a must. Doesn't matter if you don't have IV fluids, but these two things should be there. If you don't have these, see, anaphylaxis can happen to anyone. You are liable if you cannot handle the anaphylaxis and you don't have the facilities and you're administering the vaccine. So I think that is extremely important. Okay. Now we come. Okay, now we come to another case. Again, this is a case which we managed with Dr. Nitin Shah. Now, this was an 8-month infant who was given BCG at birth. He came at 8 months at age with a gradually increasing mass in the axilla. You know, you can see this huge mass in the axilla. He had low-grade fever. There was no failure to thrive. You can see the picture. It's a nice chubby baby. Okay. He had generalized lymphadenopathy and he has significant hepatosplenomegaly. Now, is Dr. Sanjay Niranjan available or no?
Yes, sir. Can you hear, sir?
With a bang.
Oh, yes. Yeah, we missed you a lot.
Oh, good,
now.
sir. You are back.
Wonderful.
There was a technical problem. I don't know, sir. I'm sorry for
No
that.
worries, sir.
No
Please-
problem.
Please join. No.
Okay, Dr. Sanjay, now what are your thoughts about this case and how will you proceed to ascertain the cause? Why this has happened after BCG? Can you please discuss this case?
Yes, sir. Yes, sir. Why not, sir? So this is a very common scenario when after BCG we have lymphadenitis with or without suppuration and very rarely a disseminated disease. So here lymphadenitis usually disappears by itself in a few months. Abscess can be drained by needle puncture aspiration from top repeatedly, and sometimes it automatically ruptures from the sinus. But this child has hepatosplenomegaly also, which means disseminated infection, disseminated BCGosis. And this is a very rare situation, 2 to 3 per million doses or per million population, you can say 2 to 3 per million. That is the incidence. So with this BCGosis, it happens usually with immunodeficiencies. So here we have a reason to investigate for primary immunodeficiencies and also other immunodeficiencies. And for this case, I think ATT would be required except pyrazinamide, which is not available in cow, this strain, Bacillus guerin. So we give INH, rifampicin, and ethambutol for 6 months in case of BCGosis and investigate for immunodeficiency, sir.
Okay, now what
Otherwise,
investigations would you
nothing.
like to do, Dr. Sanjay?
Sir,
How
among
would
the
you proceed?
investigations, sir, if we do AFB or if we do CBNET, both are positive in BCG as well as tuberculosis. So that cannot distinguish between which of the bacteria is this, Mycobacterium or Bacillus calmette. So these tests are not helpful. Only culture can distinguish between these two.
Wonderful.
AFB and CBNET both cannot.
That's an important point because presence of AFB is Mycobacterium bovis. So you got to be sure, you have got to have a culture done in this. Now we did an immunoglobulin profile and everything was normal. Okay, his immunoglobulin, GAME stands for G, A, M, and E. Lymphocyte subset analysis was normal. NBT test was normal, so no defect of phagocytosis. So in this particular situation, see, please remember what I told you is this child was a healthy looking child. There was no failure to thrive. Any other immune deficiency, the child would have had recurrent infections. So in this situation, it is very important to always consider the diagnosis of a Mendelian susceptibility to Mycobacterium tuberculosis. So when this child had an interferon gamma loop deficiency, and this was a typical case with Mendelian susceptibility to mycobacterial disease, which is commonly known as MSMD, and which characteristically causes BCGosis, recurrent enteric fevers, recurrent tuberculosis, multifocal tuberculosis, and osteomyelitis. So this was a case of MSMD. So this child did very well with antituberculous treatment. This was a child whom we were treating and then shifted to Mumbai, and Dr. Nitin Shah took over and managed this child. This child did pretty well. So basically the question is, when should you suspect PID in a child with BCG complications? Dr. Niranjan, again, can you take it, please?
Yes, sir. In cases of in the similar case, when there is BCGosis, which
Yes,
means just lymphadenitis and abscess is not the
correct.
suspicion. The two organs, distant organs, should be involved apart from
Exactly.
local tuberculosis, local lymph nodes. So
Wonderful.
two distant organs, if they are involved, then we should suspect immunodeficiency, sir.
Wonderful. So I think that is crucial. Whatever, however severe the local reaction is, if distant sites are not involved, it is not BCGosis. Okay, that is something that has to be remembered. Now, generally, which are the primary immunodeficiency conditions associated with severe BCG reactions? Can you just give us a few list of a few? Which are the conditions, Dr. Sanjay? Hello. Hello.
Sir, maybe someone else can take this question, sir.
Okay. Anyone else? Dr. Arun?
Got.
Anyone else?
Okay. Anyway, it's all right. Basically, when you have BCGosis,
Any one of them, yeah.
you got to think of either subacute combined immunodeficiency, common variable immunodeficiency, which is of course uncommon in the neonatal period, chronic granulomatous disease, HIV, and MSMD. So these are the 5 conditions you think of whenever you have BCGosis. Okay. Now, coming as a corollary to this particular question, you know, there's a blanket rule that universal recommendation for BCG for all infants born in our country, including those who are HIV positive. There is no, I mean, you see the IAP recommendation, you see the WHO, fine. Now, what are your thoughts about this, Dr. Surendranath? Should it be universal, or should you have a more cautious or more qualified recommendation? Your opinion, please. Dr. Surendranath.
Yes, sir. I must thank you for this question because I was never really bothered about giving BCG to most of the children. In one of the panel discussions, you have mentioned that BCG should be delayed in some of the patients where HIV positive mother is there.
Right.
As far as the national program is concerned, there is no contraindication to give BCG vaccine for a newborn for a HIV mothers.
Right.
But there are some riders are there. Now WHO position paper says that you can postpone the BCG vaccination at least 3 to 4 weeks till you get the PCR done. If you are, have the facility to get the PCR done, ideally is to do a PCR for the baby and confirm that there is no transmission of HIV from the mother to the baby, and then you can vaccinate these children. But programmatically, it may not be so easy to do PCR in all the.
Exactly.
For an individual baby, definitely we can do a PCR and do the BCG.
So basically, if the mother has received good antenatal care, has received antiviral retroviral therapy, good practices during the labor period, then even if the mother is positive, you can definitely give BCG as long as the infant is not showing any signs, or as Dr. Surendranath just said, you have to test. So you defer the BCG vaccine, do the test viral load if possible, and then give the vaccine if the viral load is not present in this particular child. I think this, in fact, those who are interested can read the that weekly epidemiological record of WHO. 2007 was the new recommendations which came. A very interesting articles, very lucidly explained. One can definitely go through it. Okay. Now, Dr. Arun Wadhwa's favorite topic is influenza vaccines. Okay. Now, let's have a rapid fire session. Okay. First, with the availability of a quadrivalent vaccine, do you feel there's any role for a trivalent vaccine?
No, unless somebody wants to save the cost. Otherwise, absolutely no role medically.
Wonderful. Split virion versus subunit. That your take on this?
My take is it's like splitting the hair or subuniting the hair follicle. No difference.
So no difference. Okay, fine. Now a 3-year-old comes to you for flu vaccine. He has took only 1 dose last year. This year, how many doses?
So this last year would mean calendar year, or suppose he's taken in December first dose and he's come
this is the last season vaccine.
Calendar, last season. So last season means the vaccine has changed now. Maybe 1 or 2 or maybe 3 strains have changed. So this year he has to have 2 vaccines 1 month apart. Correct. And the child has 3 years old, so he has to have 2 vaccines, 2 doses.
Wonderful.
If he has taken 2 doses of vaccine in the first year, sir?
First year and there's a gap in between, then only one dose. Suppose he has taken two
Yes.
doses in 1 year, second year he hasn't taken, and now he's come in 3 years, then only one dose.
Now we are coming to the situation. This is a child
Oh, same.
who has taken 2 doses, the first dose in 2017, second dose in 2018, and now it comes in 2020. 1 or 2 doses.
One dose.
Wonderful. So the recommendation is anytime in the
Two
past, if he has
doses, yeah.
taken 2 doses, need not be in the same season, then only 1 dose is to be given. Okay. A lot of confusion. So that's why I brought out these issues. Now, a child that received 2 doses of the trivalent influenza vaccine this year, father learns that there's a quadrivalent vaccine which is even better, and he says, can you give me that vaccine now? So will you administer a 3rd dose in the same season?
No, I would tell him to come back. Maybe I'll write down his phone number. Whenever the QIB comes for the next season, I'll call him first, but
Wonderful.
not now.
So there is no recommendation by anybody for more than 2 doses of any influenza vaccine in one particular season. I think these are some common queries. Of course, if the audience has any more queries, please send it in the chat box. We'll have enough time for discussion after that. Okay. Now we come to rabies vaccines. Okay. Now, again, this is Dr. Sanjay Marathe's favorite topic. Okay. So we will ask him to then briefly, please mention what are the changes that have been made in pre-exposure, post-exposure, and re-exposure prophylaxis. The 2018 recommendations.
If you go by the position paper 2018 on rabies, I think it has given many good changes for the management. The first thing, the intradermal doses are as good as intramuscular. And it is better than that, can be given. 1. Decreasing the number of doses or decreasing the amount of vaccine has not compromised on the quality, neither on the duration of protection. It is equally safe. 3rd, you can select any vaccine schedule as per the guidelines given in the book. 4, there is no role of intramuscular rabies immunoglobulin or monoclonal rabies antibodies. All dose calculated must be infiltrated around the wound.
Right.
4th, if the person has received post-exposure prophylaxis completed for next 3 months, even if he is exposed to any animal bite, no anti-rabies vaccine or immunoglobulins are required.
Right.
5th, consumption of raw milk or the meat of a suspected rabies, there is no need to give post-exposure prophylaxis. These are the major changes. Now coming to the schedules which has been given, which has been accepted by ACVIP also. Now I will first give the intramuscular schedule. Now instead of 5 doses to begin with, which all of us were following, now you can give 4 dose schedule. Intramuscular 1 dose on day 0, day 3, day 7, and 4th dose is given in between day 14 and day 20.
Right.
You can change it to, if the patient has come after a few days and you have no RIG and all that, you can give 2 doses of intramuscular on day 0, then 3rd dose on day 7, 4th dose on day 20. If I have to give intradermal, then I have to give 2 site intradermal 037.
Right.
This is the post-exposure prophylaxis. In category 3, I have to add rabies immunoglobulins. Now, initially we used to call HRIG or ERIG. Now, with the availability of monoclonal rabies antibodies, it is preferred over HRIG for the various reasons which we can discuss subsequently. In an immunocompromised child, whether it is category 2 or category 3, you have to treat it as category 3. As far as re-exposure is concerned, I have already discussed about the 3 months from the post-exposure prophylaxis, no treatment is required, only the wound care and all that. If after 3 months, if you come again with the exposure, then you have to give only 2 doses, whether you give intradermal or whether you give intramuscular, 1 dose each on day 0 and day 3. That is all what is required. In pre-exposure prophylaxis, now their recommendation is only 2 doses from 3 doses previously. Now you have to give intramuscular 1 dose on the particular day on which you are starting the pre-exposure prophylaxis and 2nd dose on day 7. If you are giving intradermal, then 2-site intradermal on day 0, that is starting the dose, and day 7 again the 2 doses.
Wonderful.
This is exactly what. And if I want to say a word about the monoclonal antibodies.
You're coming to that next, Sanjay.
Okay.
Excellent, excellent, I tell you. Now, one comment which I would like Dr. Sanjay Niranjan also to add on. Now, first is the government of India has still not approved these changes. Okay. So, as a pediatrician in office practice, which schedule should we follow? Should we follow the new schedule or should we follow the old schedule? Dr. Sanjay Niranjan, you're muted, please. Sanjay, you have to unmute yourself. No. I think he has to be unmuted.
Yes,
That's right. Yes,
the
yes.
host has unmuted me now.
Yeah, please start.
Sir. So, sir, government of India has not approved because it will be an off-label use, and government India is already using intradermal schedule, 2 doses intradermally every round at 0, 3, 7 days and 28 days.
Right.
So they are already using only 4 doses. When there was scarcity, they had come down to 3 doses. Now they have again come to 4 rounds, means 8 doses. 2 intradermal doses at different sites, both shoulders, each time. And for this reduction of 1 dose by intramuscular, because government is already not giving intramuscular, so they have not yet accepted because it will be an off-label use because product insert is still recommends 5 doses. So as a pediatrician IP members, we continue with the new recommendations, but DCGI has not approved, sir.
So what is it? In practice, if you get one in your clinic, which will you follow, the WHO, revised WHO or the older schedule? Just one comment from each of the panelists, please. Dr. Sanjay Marathe, which will you use?
I think I will go with the ACVIP and the WHO recommendation.
Okay.
Because if you see the paper,
No, we'll discuss. Dr. Surendranath, what will you follow?
Either of it, sir, I will follow ACVIP recommendation. Right now, I am following ACVIP recommendation.
Dr. Arun?
Even I am doing that, 4 doses.
Okay, now, which is supreme? Is it the DCGI or is it ACVIP?
For us, ACVIP.
Legally? I think I don't want to confuse the audience, but generally, I think what we follow should be also DCGI approved. Or if you're going to follow the abbreviated schedule, you have to explain to the patients and tell them, but you have 2 schedules, one with lesser number of doses. It is equally good, but the government is still not approved it. And it has to be an informed consent has to be taken. I think you have to be very careful about this.
Is this the NCDC or the DCGI, or are they same? Because NCDC has not approved. The DCGI will approve the vaccine. The doses, I don't think.
Okay, whatever the National Regulatory Authority has not
NCDC.
approved the vaccine.
NCDC.
And the National Regulatory Authority is the drug controller, not NCDC. Okay, so I think this is what I think this topic has been raised so many times in so many fora, and this is the sort of consensus that has been arrived at regarding this. Okay, now let's come to another situation. These are all from my own experience. A 5-year boy had an abrasion with some bleeding followed by a bite by a stray dog some 3 months back. They didn't do anything about it. But after 3 months, the mother gets the news that the dog was suspected rabies and was killed by the people. So in this situation, what should you do? 3 months, nothing has happened. So will you keep quiet? Will you give rabies vaccine or you will give the immunoglobulin and the rabies vaccine? Dr. Surendranath, can you take this question?
Sir, I will give immunoglobulin and the vaccine, sir, because the incubation period of the rabies is a prolonged period.
Right.
So definitely we have to give immunoglobulin and the dosages, whatever recommended we have.
Wonderful. So this is 3 months. Suppose the child comes after 1 year or after 2 years. What is your take on that? Will you still go for the same?
I will give the vaccination, sir, whether it is useful or not, or it is a pre-exposure prophylaxis also, it will work. I think we have to give the vaccine whenever the patient comes, definitely.
Any other comments from the other panelists?
No, sir. Sir, I will go with this. It will go legally also.
Yeah.
The incubation period could be up to 2 years also.
Exactly.
So we'll have to give RIG as well as we'll have to give all the full doses of it. The
Except
recently
wound
what they
cleaning, treat
say,
it like
the
a fresh.
WHO
Dr. Arun.
recently say, which has not been accepted, that the chances of having disease after 12 months of
Yes.
history
Yes.
of
Right.
animal bite is almost equal to nil. But that is not going to help you legally. So if
Exactly.
legally speaking, I would like to give RIG as well as the ARG.
Exactly. See, if you see the WHO position paper, what they clearly say is, if there is shortage of vaccines, then you put the cutoff as 12 months. Otherwise, at least 2 years.
Yeah.
Okay. So I think this is another message. So even if the bite is old and it's a category 3 bite by a suspected rabies dog, treat it like a fresh bite. I think that is the message I want to convey very strongly to the audience.
May I have one?
Treat it like a fresh bite, except wound cleaning.
Yes, except there's no wound now. Right.
May I have one comment, sir?
Yes, yes.
Sir, if the child is asymptomatic, then we can give the vaccine at any time he comes, even after 2 years. That
Exactly.
I think.
Yes, that
Yes.
is right.
And
But
about
you have to,
immunoglobulin,
but you have to
yes,
give a post-exposure prophylaxis, not a pre-exposure.
right, sir.
Right.
And
Okay.
immunoglobulin, because the local infected sites are not available by that time. So about that, I am not sure, sir.
Yeah, I think this is, if the child of the mother can specifically point out the site of the bite, you can again infiltrate locally. But
Yeah.
there is really no idea in giving intramuscular immunoglobulins. Okay. Now, suppose there is an exposure to the oral mucosal membrane. What will you do? Where will you give the intramuscular? Where will you give the immunoglobulin? I mean, suppose there are aberrations in the oral mucosa and the child has consumed milk from a rabid cow. What are you going to do?
Nothing.
Yeah, Dr. Sanjay.
Okay.
Marathi.
The recommendation is the local irrigation with the rabies immunoglobulin or monoclonal antibody.
The child is 2 years old and cannot gargle. What will you do?
So what we can do, we can dilute the rabies immunoglobulin and flush the mouth if it is possible, because that is the only way where you can give apart from the ARV which you are giving.
I think
Because
there are
giving
only,
intramuscular is away from the site.
no, see, giving intramuscular RIG or monoclonal antibodies is recommended only in 2 situations. One is oral exposure and secondly exposure to bats, aerosols. These are only 2 situations where the CDC recommends, okay, intramuscular immunoglobulin. Apart from this, there are no indications for intramuscular immunoglobulins. I mean,
WHO recommends
extremely
local
uncommon
irrigation.
situations. Okay.
But when you swallow milk from an infected cow, then you don't need any immunoglobulin or a vaccine. So milk will not cause.
Okay. I mean, some exposure of the oral mucous membrane with aberrations.
With abrasion.
Okay.
Otherwise, no.
Yes.
Once I
Quite
had a
common
child.
with the anal mucous membrane getting exposed with the dog bite, or sometimes if there is open
You can
defecation.
definitely. Yeah. So when mucous membrane, this is the only situation. Okay. Now, yeah. Now, Sanjay, you take over. You're very keen on this. Can you comment single component? We have now 2 rabies monoclonal antibodies. One
We
is
have
single
2
component and the other one is 2 components. One is human, the other one is murine. So what is your take on this?
So now we have 2 monoclonal antibodies available. One is the totally human single monoclonal human rabies antibody in the name of Rabies Shield by Serum Institute. And now recently Zydus has introduced murine cocktail.
Yes.
Murine cocktail of 2 monoclonal antibodies. See, if you'll see, there are some advantages with both. There is no head-to-head comparison.
Right.
In both the things, they have demonstrated adequate neutralization of almost all the rabies subtypes which are available, which are seen in our country. Except in a human monoclonal antibody, there is one only subtype which is seen in the Peru, which is not seen in our country.
Peruvian
So
bat.
practically speaking, both the monoclonal antibodies are very effective, very safe, can be used in our country. Whatever is available at that time, do not wait for any particular type of monoclonal antibody because this is better than that. At present, the take-home message for all of us that use monoclonal rabies antibodies and you can say should be preferred over the HRIG or ERIG. It is cost effective and And it is very safe and effective also. It is better than in all the comparison when the comparator was the HRIG. It has shown on day 14, the antibody titers with both the monoclonal antibodies and ARV is better than HRIG with antibody, ARV. So we must use either whatever is available at that time. Both are equally good and very potent.
I think that's very good. Now, even if both are available at the same time, I don't think there's much to choose between the two as of available data now.
Except the cost. Except the cost.
Cost is going to be a little different. It's going to be a little more with the.
Otherwise, both are equally.
Yes, there's not much of a difference, but the monoclonal antibody has to be used. Okay. Now we come to HPV vaccines. You offer a 10-year-old child, comes for the Tdap, you say, why not the HPV? The mother says she's too young to get HPV infection. Why can't we wait till she's a little older, maybe 18, 20 years? Dr. Wadhwa, very briefly, 1, 2, 3, 4 points, why we will tell the mother, yes, you have to take it now.
I think this was a question, people used to ask earlier. Now I think people have started accepting. But when they ask, usually I tell them that I think for the patient's point of view, most important thing is that 2 doses are required. You can save on 1 cost.
Correct.
But from our medical point of view, it gives them the best immunity. And if you have a coverage of more than 80%, then gives a herd immunity, protects the boys also. Right. And immunogenicity is same, like I told you, 2 doses give as good as 3 doses. And it has to be given before the onset of sexual debut. So this is the right time to give it. And you can mix with other vaccines like DTAP, or not mix means give it at the same time. Same visit can be utilized for 2 vaccines. But immunogenicity is the best, the most important reason.
I think that is very, very crucial. It is definitely far better immunogenicity. And second, of course, you're reducing one dose, which is quite
from
significant.
From parents' point of view, that's important.
So I think that's great. Now, you give now at 10 or 12 years, how long do you expect the protection to last?
So protection we'll know only with time. The vaccine came in 2006. It's already 14 years. They have been following a cohort of children. Quadrivalent vaccine has data till 14 years. It has been protecting. And I think the bivalent vaccine has data till 9.5 years. It's been protecting till now.
So basically,
it should be lifelong.
Yes, it has to be lifelong because the protection that is needed is at the mucosal level. And you require very, very minute quantities. And remember, HPV is a long incubation period illness. There is time for the anamnestic reospan to occur. So generally, I think the protection will be lifelong with if the adequate number of doses are given. Okay. Now, this question goes to Dr. Sanjay Marathe. Very often when you offer the vaccine to the 10-year-old child, the mother is more interested in taking it rather than giving it to her daughter. Now, is it, and we know this is a prophylactic and not a therapeutic vaccine. Is it worthwhile vaccinating an older sexually active woman, maybe a mother who is about 35 years old or 40 years old? What are your views on this topic? Dr. Sanjay Marathe.
Yeah, sir, I think now we should not have any doubts about it, that there are many studies conducted in our country as well as outside, that the protection offered to the sexually active women when they are exposed to the HPV is significantly, we can say, protective and long lasting. There are a couple of things. The counseling of the parent, the mother will be very important. We'll have to tell that the protection offered may not be as good as the protection which was given between 9 to 14 years.
Yes.
If she is fortunately DNA negative at the time of vaccine against the vaccine containing serotypes, that is 16 and 18, the protection offered will be as good as the one who has given at 9 to 14. If she is positive for one of the two, the protection will be little less. She will get advantage of this vaccine even if her pap smear is abnormal. Still, you should continue giving it.
Right.
And the studies are up to the age of 45 years. So recommendation is also up to the age of 45 years. And there are very good studies. One I can quote is Patricia's study with the bivalent HPV.
Right.
And where it has demonstrated that the protection is not only very good, immunogenicity or immune response is very good. The long-term protection at that time, they say almost for 10 years, it was no reduction in the protection. Another study will be almost 400 women who are included in that multi-centric trial. And it has also given almost the same. So even if she has crossed the age of 15, and we should always remember there are two peaks of HPV. One is between the age 15 to 19 years, and second is usually at 4th to 5th decade. So if fortunately the mother is not exposed, then she will be benefited with the second peak of HPV, and they must be offered. And when you give vaccine to your patient, that is the time to sensitize mother to take the vaccine.
Wonderful. So I think basically what is equally important, there's another study also, which was an offshoot of the future study, where even in those who were DNA positive, vaccination definitely reduced the number of gynecological procedures, colposcopies to the extent of 40%. So even in those who are DNA positive, that is sexually active women, there's definitely a definite role for HPV vaccine. So we should not discourage these mothers saying that it may or may not be useful. Please remember, for recommendation of any vaccine, the most important factor is a strong recommendation by the healthcare giver. So if you are ambiguous, it will not work. You have to be definite. Only then will the vaccine uptake increase.
So
Right.
one more point, sir.
Yes, yes.
As a postpartum vaccination, success is very good.
Yes.
Absolutely.
There are some studies which have shown that even in postpartum mothers, only 20% of people are positive for HPV 16 and 18.
Wonderful. That's a very good
Some
point.
people are not exposed to the vaccine. Nowadays, postpartum vaccination is a very good chance to vaccinate the women who have not taken the vaccine.
Wonderful. That's a very important point that you have brought up. Now we know that for those less than 14 completed years, it's a 2-dose schedule, which should be 6 months apart. Now this is a 10-year-old who by some mistake was given the second dose just after 4 months. Dr. Surendranath, is it a valid dose? If it's an invalid dose, when will you repeat the dose again?
The exact recommendation is there should be a gap of at least 6 months between the two doses.
Right.
Minimum interval, what is specified by the ACIP and CDC, say that 5 calendar years, if the gap,
calendar months,
that is acceptable. That is the minimum. At least 5 calendar years, there should be a gap from first to second dose.
Dr. Surendranath, months.
Yeah. For
Yes.
5 months, sir.
Months.
It's 5 calendar months.
Right.
Gap from first and second dose. And this child received the second dose after 4 months. That means it is invalid dose. You can give another dose from this point to there should be a gap of at least another months to give the vaccine from this point.
I think the recommendation is 12 weeks. Am I right, Dr. Arun?
Yes.
I think the recommendation is 12 weeks.
12 weeks, that's right. There has to be a gap of at least 12 weeks after the invalid dose. Only then can you give the vaccine. I think these are some issues about the HPV. Okay. Now I come to
12 weeks? I think it's 4 months. 4 months from the second.
No, 12 weeks.
12 weeks.
12 weeks minimum. Ideal is 4 months.
Recommendation is that there should be a gap of at least 12 weeks from the second.
At least 12 weeks, but ideally 4 months.
Right. Okay. Now
it is a very clear recommendation is there, sir. From first dose to the second dose, at least 5 calendar months. From the second dose to the third dose, 12 weeks, sir.
12 weeks.
12. Absolutely.
Now let's come to another situation. Very interesting situation which I encountered in my own practice. Mother was diagnosed as high-grade cervical cancer and is on chemotherapy. Her 15-year-old daughter is brought by the father for vaccination to me for HPV vaccine. She flatly refused to take the vaccine. I don't want the vaccine. I mean, some fear. It is just, no explanation. She just said, I don't want. Sat down, spoke to her for quite some time. She just refused. Called her on 2 occasions, both the time she refused. So third visit, the father came with 2 hefty uncles and said, doctor, just don't ask. We will pin her down to the examination table. You give the vaccine. Okay. So can you administer the vaccine forcibly and against her wishes? Now, I want each panelist to just answer yes or no. We will discuss later on. Who is for yes, who is for no? Amongst the 4 panelists, anyone opting yes, no. I will give the vaccine under restraint?
No.
I would say no.
I will
so everyone, Surendranath?
For an adolescent girl, it is no, sir.
Okay. Dr. Sanjay Niranjan? He's again gone. Okay. So basically here it is legal versus ethical issues. Okay. Now, if you see, I don't know whether Dr. Mulial is watching this or no. There are these major issues: autonomy, non-maleficence, beneficence, justice, and harm principle, whenever you're talking about ethics. Now, if you consider each one, legally you have the parental consent. Legally, you're right. You are under you're right in the law if you forcibly also give the vaccine because parental consent. But the adolescent is dissenting. Is the vaccine safe? Yes. Is it of benefit? Yes. Will it protect the community? No. Individual vaccine will not protect. Will not vaccinating her pose a significant risk to her health? Here, generally, the answer is no. Okay, because by not vaccinating now, there is no risk of her developing HPV in the immediate future. Okay, so here, this is not a life-saving procedure. So not giving the vaccine will not endanger the child's life. So this 15-year-old adolescent cannot be vaccinated without her assent. This is the concept of what is known as the mature minor. Any comments from the panelists, please? Anyone disagrees or has any dissent on this?
Agree.
Absolutely.
All agree. Suppose this was rabies vaccine for a category 3 bite, then does it change anything?
Yes, then it's a life saving.
It's life saving.
Yeah.
Okay, so then you will, under restraint, you will give it to her because you can't call her again and again for conversation. So I think again, the audience, I want to understand them to understand that if it's a life-saving procedure, some amount of force is fine if there is very, very strong reluctance, in spite of trying to convince her in a reasonably short period of time. But if it is not an emergency procedure, for a 15-year-old girl, pinning her down and giving the vaccine is extremely traumatic for her, and it should just not be done. Okay, I think this is something very important, not specifically vaccine, but holds for any other procedures. Now we come for nothing can end without COVID. Okay, in any discussion. What is the status of COVID vaccines? Dr. Arun, I just want you to talk which are the vaccines now in phase 2, phase 3 trials, and when can we expect the vaccines to come into clinical usage?
But now everybody is reading from the WhatsApp university newspapers. Yes. Everybody is aware of this. So I think
let's have some scientific data.
Russian vaccine, which everybody's been saving, has been launched, is actually in phase 2 trial only. Phase 3 is about to start next week.
What type of vaccine is the Russian vaccine?
It's a viral vector vaccine. So they don't write what exactly, which viral vector, but it's a viral vector vaccine. So the ones which are in phase 3 trial, 2 are in China. The one is a chimeric vaccine, the other one also a chimeric vaccine, and the Moderna vaccine, which is the USA vaccine, which is mRNA vaccine. And in India also, the Serum Institute has started today only the phase 3 trial from Pune. And this is also a chimeric vaccine, adenovirus chimeric vaccine. So this is in phase 3 trial from today. Then we should be more bothered about the Indian vaccines, because the Western vaccine, Chinese vaccine, most likely will not come in India soon. So we have to follow our Indian vaccines. And most likely the first vaccine to come will be the Oxford vaccine, or we say what is the Serum Institute vaccine, which they have labeled as Covishield. So they've started phase 3 trial today, and by the end of the year, hopefully we should have. And they have said that they'll be manufacturing 400 million doses by the end of the year. So we should have the vaccine. The most important thing will be who will give it, who will get it first, and the government most likely will take it over. Most likely the government will decide who has to take. So probably healthcare professionals, police, army, then the politicians, their relatives, and then probably the patients will get it. So not before. And our children will probably be the last one to get it, because first they'll have to give to the elderly population, then the comorbid population, then the adults, and then the children. So children, patients have to be told that don't expect a vaccine for a child before the end of next year. So this is the vaccine I feel would come first. The other one, the DNA plasmid vaccine, the Cadila vaccine, has just started the phase 1-2 trial. They've had 12 centers, 11 cities. They have enrolled around 500 people, but it's again a vaccine which has never been tried. DNA plasmid vaccine, there's none. The interesting thing was that, these people are trying an intradermal vaccine by injecting by a pharma jet, so it might be turning out to be a different kind of procedure what they're trying. So 0.1 ml intradermal or by the jet. And the third most important, even better than probably the Zydus vaccine, is the Bharat Biotech vaccine, the Coru flu vaccine, which is a whole cell inactivated vaccine. It will provide good immunity because all our vaccines till now are whole cell vaccine, whether live or killed. The only point would be that it might take longer to come to our clinics because whole cell vaccines are known to cause side effects. They are known to cause ADE also, so they'll have to research it for a longer time. But it is on the cards. It has been designed by ICMR, NIV, and given over to Bharat Biotech.
Okay, one quick comment from you, Dr. Arun. There is a fast tracking of all these vaccines. Do you think the safety is being compromised by fast tracking the vaccines?
First tracking, yeah, definitely it's compromised because phase 3 trials are being cut out. So that is why people are saying that, especially in America, that they may not take the vaccine. And the only other answer could be doing a human challenge trial. Correct. So lots of people have enrolled for the human challenge trial.
Yes,
there's a site there one day sooner. There's a site where you can enroll yourself.
Correct.
I also went to the site and just to see how to enroll. And there were almost 28,000 people already enrolled there. But WHO hasn't given a clearance, and they might start doing this human challenge trial. That can fast track really fast. The vaccine can come in fast then, like what they did for the TCV in Oxford University.
Right. Thanks. That's a good comment. Quick comment, MMR and COVID. Dr. Sanjay Marathe.
I think all of us are getting more inquiries about MMR rather than any other vaccine at present.
Right.
And I think it started with a couple of things. Basically, there is structural and functional similarity between the SARS-CoV-2 and the measles and rubella.
Right.
With the S protein of the SARS-CoV and the H protein of measles. Then it was thought that the measles give, or the MMR vaccination gives some kind of protection to most of the viral infections, so it will protect the COVID also.
Right.
The significant decrease or less incidence in pediatric population was thought to be because of the various vaccine, and MMR was one of them. The hypothesis for MMR was it basically stimulates, or through the trained innate immunity, by training the immature leukocyte in the bone marrow through the MDSC, that is myeloid derived suppressor cell. Means it suppresses the inflammatory response. As we have all seen that the maximum mortality was associated with the inflammatory response in the lungs, they thought that if we give MMR, then it will reduce the inflammatory response. And the fourth reason why, because there is 30 amino acid analogy between the measles, rubella, and the COVID SARS virus. But to be very frank, and the take-home message for all of us, there is not a single authority who has said that a MMR vaccine should be given to give any protection for COVID.
Right.
And it should be very clear. There are no studies going on at present to recover for any recommendation. Secondly, we have no conclusive evidence from any of the studies before. Third, the MMR vaccine should be given to the elderly for the protection of measles, mumps, and rubella, and not for COVID protection. Or if you want the COVID protection, then you should wait for the COVID vaccine, which Dr. Arun has already discussed in detail. So no MMR for the protection of COVID.
Okay, BCG and COVID.
There are 2-3 trials going on. One
yes.
was
Yeah,
Cairo.
trials are going on, no recommendations have come.
Yeah, no, they are trying that Cairo. They have doing. There are 2 trials in America. They're trying MMR.
They're doing it in Netherlands also.
Yes.
Right.
So, but no recommendations have come. No conclusive.
No, not at all.
Dr. Surendranath, BCG and COVID. Quick response.
For a COVID patient, BCG or BCG for a COVID? 2 things are there, sir.
So you talk about BCG for COVID, for prevention of COVID.
So as far as the BCG is concerned, we all know that it is a non-specific immune booster, something like it boosts the innate immunity.
Yes.
There are sufficient number of papers which have shown that respiratory infections in a BCG given individual is 50% less, and even under 5 respiratory infection rate has come down in fact, and BCG is used for some of the immunomodulatory effects even in the cancer also.
Correct.
So taking this into consideration, BCG is a non-specific innate immune booster, and in turn, not only COVID, it can prevent some of the viral infections also. So there is a hypothesis saying that whatever cells are there, whatever myeloid cells are there, they are primed with BCG. They are better equipped to deal with other viruses, in fact, and immunological response for the other viruses and severe bacterial infections has been found to be helpful for BCG. But this effect is seen only for 1 year after the BCG vaccination. That's what has been described in some of the papers. So as a COVID prevention, BCG as a second dose to give the elderly person, it is not yet recommended, and WHO categorically said that BCG should not be used to prevent the COVID.
Fine, thank you. What about Cep-C-Vac? Anyone can answer?
Which one, sir?
Cep-C-Vac vaccine. Anyone?
Mycobacterium, MBCG.
Yes.
So Cep-C-Vac has been used for prevention of sepsis, and they have made formulations like 1 dose, 2 dose, given 1 week apart for treatment of sepsis. Again, the same thing. It induces the innate immunity, and but again, there is no reason to start give Cep-C-Vac here for COVID.
Okay.
Similar thing, innate immunity, same thing what described for BCG.
Thank you. So as of now, I think the message to go out is MMR is against measles, mumps, rubella, and not COVID. BCG against tuberculosis, not against COVID. And I think we should stick to that till we get more data. Studies are ongoing, both for MMR and BCG. Till we get the results, I think we should not. But remember, one thing I would like to say as far as MMR is concerned, if you have not had a history of MMR vaccination and you don't have any definite proof that you've had the disease, even if you're 40 or 50 years old, it's worthwhile taking the MMR. Okay, if it helps against COVID, fine. Okay, now
one question, sir.
Yes.
In the ACVIP now,
yes,
there is no recommendation of MMR for healthcare workers in our guideline book till now.
Exactly. I think
so I think we have to add that one.
Definitely. I think that's a good suggestion. We will definitely take it up. Now I come to the last question, something which I always wanted to discuss, but always scared to rake it up. What I want to ask is it mandatory to follow guidelines, ACVIP guidelines? See, sometimes you don't agree with. You say when the ACVIP said give only WP, there were many people who didn't feel comfortable. When the ACVIP says give only 1 dose of typhoid conjugate, many people are not comfortable. What are your views on this? Or someone is interested in giving a 2-4-6 schedule, month schedule, rather than a 6-10-14 schedule. And there are people doing that in our country also.
I don't think it is mandatory. It is not mandatory, but definitely some kind of the book which is available as a suggestion which is given, which is based on the scientific information. Because almost 95% of the people will have no knowledge of all these things. But then it is not compulsory for some pediatrician to follow this. He can follow CDC guidelines.
Okay. Are there any legal implications of not following the ACVIP guidelines?
If he's using a very erratic schedule which is not recommended by anybody, then definitely he is legally bound to have some problems. But suppose he's following CDC or something, but
any other comments, Dr. Arun?
CDC guideline.
Dr. Arun?
Guidelines are meant to guide you. You can't be like forced to follow those guidelines, but legally it's safer if you follow the guidelines. But in this case of WP, AP, if you don't follow, you give AP, I don't think legally you are wrong too.
Correct. Okay, Dr. Surendranath, any comments?
As Arun told, they are only the guidelines which are guided for regular practice. In fact, to fall back for a legal opinion, I think ACVIP guidelines, if you follow, maybe legal to some extent you are safe.
I think basically these are guidelines, these are not commandments. As long as you're following any schedule or recommendation which is recommended by a national or international body, I think you're legally safe. It need not be specifically ACVIP guidelines. I think with this, I have finished my panel, and the panelists will be very happy to take any questions. I do not know how many are there.
There are quite a few, but Sunil Agarwal has very
a good number are there, sir.
Already answered most of them.
Sunil Agarwal is doing the job.
Anyway, sir, Dr. Kashi and team of Dr. Arun Bathwa, Dr. Surendranath, Dr. Sanjay Marathe, and Dr. Sanjay Niranjan, that was an excellent session. You are covered right from, I believe, all the UAP vaccines, BC, DTaP, DPT, BCG, BCG adenitis, then rabies in different scenarios, and coming to COVID in the end, and COVID vaccine, MMR, COVID with MMR. So that was you took us through the entire gamut of vaccines, the controversial issues, I believe, most of the controversies which have come up, and especially from your own experiences, most of the panelists were quoting, and from your experience, we have got quite a good number of questions, sir, from the platform. I believe we can take another 15 minutes and we can 15 questions, I think, if it is possible.
Come on, start.
It could be a fast track, something like, what about a booster dose at 15 years? Anything, and a catch-up schedule of meningococcal vaccine? Dr. Kusum Kalla would like to know. What are the vaccines at 15 and 16 years you would advise for a child?
Okay, who? Dr. Sanjay Marathe, you please start.
Be quick.
Yeah. As in India, we cannot give the recommendation of giving booster at present because we have no studies available for the incidence and prevalence. For us, it is still a disease which is there in the outbreaks at certain particular parts. So we cannot recommend any booster. Whereas in America, they have definitely designed the need for giving a booster because their maximum incidence is seen around that adolescent and late adolescent period.
Right.
So they give first dose and it has seen that the protection usually lasts for 5 years. So they say give another dose as a booster at the age of 16. But similar recommendations are not there in our country.
Right.
What is available with us is the DCG has approved for less than 2 years, which is our priority where it is associated with lot of mortality. But we have not identified the risk or the severity, the incidence wise or the prevalence wise in the adolescent age group. So in India, there is no such recommendation of giving any booster at that particular age. So this is there in the America.
Done. What's the next
In
question?
India, the boosters will be given only to 8 clinic children.
So we would like to have the questions in brief, the answers. Which booster is advised at 16 years of age? Tdap, DT, or TT?
None of them.
He has not taken Tdap.
So if he's taken at 10 years, then nothing till 18 years.
18 years. Fine, you don't give no vaccine at all.
If it's taken at 10 years, then at 18 years, you can give TD.
Suppose not taken at 10 years.
You have to give Tdap.
You have to give Tdap followed by TDT.
I think just give, please give one clear message to the audience.
So if the patient has taken Tdap at 10 years, then you don't need to give anything till 18 years. If the patient has skipped the 10-year Tdap, then at 16 years, you can give a Tdap.
Wonderful. Next question, please.
Okay, that's fine. Is it the IPV at 9 months in government centers? Is it possible, or if so, who cannot take IPV earlier or miss the doses, will you provide this? What is your take on this?
You mean IPV at 9 months?
9 months.
Yes. Any response?
Unfortunately, the government of India in their public health, they are not giving any IPV doses even if he has missed it.
Correct.
So even if you refer them to government hospitals, they will not give because they have very structured program. Give intradermal at 6 and 14 weeks and nothing else.
Exactly.
So even if you refer them to public hospitals, I don't think they will take up this issue and give intradermal.
Done. Thank you. Next question.
That is the real problem. Even if I refer the patient at 5 months, they will say, no, we cannot give at 5 months. There are no such recommendations.
Yeah, Dr. Ramesh.
Yes. Fine, that's very clear. Dr. Lashi would like to know whether whether all doctors need to take DTaP, and if it is so, any DTaP every 10 years, something like, you got any recommendation on that?
Dr. Arun?
Doctors.
I would say when you give Tdap for a public use, Tdap every 10 years is not worth giving, but for a doctor, it's worth giving. I take Tdap, I've taken in 2010, I'm going to take it this year again. Tdap every 10 years.
So you recommend it every 10 years?
For doctors.
Possible. For doctors.
You said for doctors, no?
Yeah, fine. For occupational risk
I
doctors.
think, Dr. Ramesh, one small comment about what Dr. Arun said. Please remember, Tdap protects against moderate and severe pertussis in the vaccine. It does not reduce nasopharyngeal colonization. So a healthcare personnel who is taking repeated doses of Tdap will not suffer, but he can transmit the infection to others. So it can be counterproductive. So I personally feel it's not really worthwhile taking it every 10 years. Okay, Dr. Ramesh.
But I believe there's a difference in that, the takes on that. Dr. Vatwa is taking it. So it's up to, fine. So prophylactic vaccine for a 30 and 60-year-old person, in the sense, Dr. Neeraj Sharma would like to know about it. At your 30 age, would you recommend something? At your 60 age, would you recommend something as a prophylactic?
Come. Surendranath, you have been very quiet. Can you answer?
I didn't follow, sir. 30 years and 60 years.
Yeah,
Yeah.
for a prophylactic, not a specific.
For doctors or for lay patient?
Prophylactic for what?
For a public.
No. What are the recommended vaccines for a 30-year-old man and a
Exactly.
60-year-old person?
For a 30-year-old man, only the high-risk persons will require some of the vaccines. And routinely, if he has already received all the doses according to the schedule, there is no need to give any vaccine at that time. 60 years.
I will
What
give
about
a
annual
typhoid
influenza?
vaccine.
Will you
No,
go for
Annual influenza can be given, sir. That is left to the patient if they are.
Okay,
it's
fine.
not recommended, no?
Even typhoid vaccine can be given.
I'll give a typhoid vaccine at 30
Even
years.
I will give typhoid vaccine.
TCV.
Exactly.
Yeah,
This
it's
is what you would
recommended.
like to know. You give typhoid vaccine, you give flu, then
Yeah.
anything
It
else?
depends,
Tdap
whether he's
can
had
be
chickenpox or not. Suppose, ask the history. If he's had chickenpox during childhood, we should give chickenpox. If he's
Wonderful.
hepatitis B, whether he's vaccinated or not. If he's not vaccinated against hepatitis B, I'll give that also. And if it's a lady, I'll give HPV also.
Wonderful. Hey, excellent.
Yes,
Excellent.
you have covered everything, sir.
Very
That's
complete.
fine.
What about 60 years old?
6 years, if we have to ask his history, about comorbidities. If he's perfectly fine, I would rather tell him to take a flu vaccine, come at 65 again. Take the flu vaccine every year and come at 65 for the pneumococcal vaccine.
Why do you want to wait till 65? Why not earlier? Why not 50,
Normally,
55?
if he's perfectly fine, there are no comorbidities, I can wait till 65 for the pneumococcal vaccine.
I think the recent recommendation by the most of the Thoracic Society of India and all that, they recommend after 50 years of age, if having a comorbidity.
That's what I'm saying. If he's not
There
comorbid,
is
I'll
no
wait till
comorbidity, you
65.
can give. Yeah. But then we'll have to give PCV 13 and not like USA where they are giving PPV 23.
No, we'll give
It's
30.
an American way of giving.
Okay, fine.
So, sir, do you feel many of our colleagues in this age group, are they following this, something like?
They
should
should.
follow.
They should.
They should. And I think IAP has always talked only about childhood immunization. I think something we should talk about immunization of healthcare personnel also. And I think I'll definitely we'll do something from the ACYP.
Exactly, sir, because immunization is our domain and other
Right.
specialties are not much concerned about immunization.
Right.
And unless and until we vouch for it, especially in the older age, being
Right.
immunization experts and we have done a lot of studies on literature, we should be the advocates for
Right.
the immunization even when we get old or for the others also. We
Right.
must come out with some recommendations.
Right.
Vaccination for splenectomy, I believe it has been covered, Dr. Kusangalla, PCV and PPV 23 doses. Just brief one line. Vaccination for a splenectomy patient.
Ideally, you should plan vaccination 15 days earlier than splenectomy if it is an elective splenectomy. If it is an emergency splenectomy, you can start giving the vaccines after 15 days. Usually, we should cover
PCV, pneumococcal conjugate, pneumococcal polysaccharide, just one word.
pneumococcal conjugate should be given first, followed by polysaccharide vaccine after 3 months. You can repeat one more dose of polysaccharide vaccine after 5 years. And
That's very clear. The recommendations are very clear on that.
I would like to add one thing. In a splenectomized patient in the age group of 2 to 5 years, you must give 2 doses of PCV 13 with the gap of 8 weeks.
Yes.
And then followed by PPSV 3. That is the only condition where you have to give 2 doses of PCV 13, even if the age is between 2 to 5 years. And after 5 years, the recommendation is 1 PCV 13 followed by PPSV, as Dr. Surendran has said.
Right.
So between 2 to 5 years, the recommendation
But
is
give 2 doses of PCV 13, 8 weeks apart, if
Yeah.
not previously immunized. If it's already previously immunized, then you have to give only 1. So if unimmunized child who is either surgically splenectomized or functional or splenia, not immunized before 2 years, you have to give 2 doses, 8 weeks apart. If the age is above 5 years, you have to give only 1, followed by PPSV 23 after 8 weeks and second dose after 5 years. But
Thanks, Sanjay
exactly
and
the
Suren.
situation in thalassemia is not there. You do not have to give 2 doses of PPSV 23, you have to give only 1.
Right.
Thanks,
These
Sanjay,
are
as well as
mostly
Dr.
Western
Surendra.
guidelines. In splenectomy patients, we should give typhoid also.
Yeah,
They don't have
it's a
typhoid,
good-
they don't write typhoid. But
Right.
All
All
capsulated
typhoid
organisms
all
should be
capsulated
covered.
organisms, yeah.
Yeah, Dr. Ramesh, next.
Post-chemotherapy, kill vaccine after 6 months and live vaccine after 12 months. What's it like? Dr. Mallikarjuna would like to
Yeah,
see
approximately.
post-chemotherapy.
Yeah.
That's a recommendation.
That's the recommendation. Yes. In fact, it is the live vaccines will give 12 to 24 months. And you'll give beyond 24 months if there's any evidence of graft versus host disease for which the child
They will
patient is
further
undergoing
delay.
immunosuppression. See
Fine.
that it depends upon the time taken for immune reconstitution. That's the reason why these 6 months and 12 months and 24 months have been made. Yeah.
That's clear, sir. Dr. Marin would like to know, is revaccination required after high dose chemo?
Sanjay answered that it is
Yes.
definitely
Yeah, it
necessary.
has to be given like an HSCT patient.
Yes. Next.
Anyway, this is covered. Dr. Chandrasekhar, what vaccine after 50 years? I believe we have covered it already.
Yes.
How do you define a season for influenza vaccine? Such any ambiguity on that season?
Who would like to
because
take it? Arun?
Huh? Which one? I didn't understand the question.
Any
Season.
how do you define a season? For
Season.
influenza vaccine, we always say season.
Season would mean whenever you have maximum number of cases. So except for Jammu, Kashmir and Tamil Nadu, where they have in cases morely in October, November, December, rest of the country will have in the rainy season, June, July, August. So that's a season when you have maximum cases.
You have
That's
in the month of May. Whatever vaccine is available at that time, it is ideal to give at that.
In
So
North India,
basically,
we are
to be very clear about it,
in the early
except for Jammu and Kashmir and the southern tip of India, especially Tamil Nadu, which receives a northeast monsoon, rest of the country, it is usually in the monsoon, that is during the southwest monsoon, June, July, August, September. Tamil Nadu gets its monsoons in November, December, so usually that is the peak season. Jammu and Kashmir behaves like a temperate country where you have the peak only in the winter and a very, very small peak in summer months. So these are the recommendations as far as our country is concerned.
so this seasonal recommendation is a recent one because the climate keeps changing. A lot of changes
This
happening
is a
around.
generally accepted recommendation.
It's based on the WHO findings of those
Yes.
12 centers where maximum cases happen.
Yeah.
Dr. Ayub Roy has come up with the medical legal aspect of rabies vaccine
Of which
documentation. Rabies vaccine.
No, as I said, I think there is no satisfactory answer for this, except that what is supreme? Is it DCGI approval supreme or ACYP supreme? And whenever we discussed with some legal experts, and I had done it because this question has been raised so many times, the legal opinion is that if you're anything that is not there in the product, insert is off-label. And it has to be done under written consent only. Informed consent, sorry.
HPV vaccine in boys, can it be given or what's any recommendation? Clear guidelines.
Who would like to take it?
Dr. Kalpana Datta.
HPV vaccine
can
in
be
the boys
given
is
to boys, but
recommended in
not in-
America.
What
No,
about
It's even very fairly good.
As far as
Yeah,
India is
65%
concerned, still it is not
recently-
recommended.
Yes.
Only the nine-valent vaccine has permission to be given to the males in India. In fact, DGCI has given
India.
permission for a 9-valent vaccine, I think. But as far as quadrivalent and bivalent vaccines are concerned, still permission for the boys is not there in India.
But how have they given for boys 9
Am I
million?
correct?
Very surprising. But the vaccine is not available with us.
did they give
and
it
They have
to-
given permission for it to be given to the boys.
They have already applied.
But I think that is perfectly justified if the boys are also given the same vaccine with very good
Yes,
protection.
yes, but what present recommendation is not at ACVAP is also
Yeah.
not recommended.
See, it is not even available in
sir.
our country.
Right.
But in
And
the
I
Western
think
country,
even
it
for
is
the
given to everybody.
quadrivalent vaccine, there is no recommendation for males in our country.
Yes.
Okay. Once
Sir,
the recommendation comes, then we can start using it.
I
Yes.
think one thing we should add, if you have to give it, somebody is traveling, somebody comes and says, I have to give it, then give the quadrivalent vaccine, not the bivalent. Don't say.
And
cost-
again, you should have a documented written consent for giving it.
Sir, I gave to some of the male children because the doctor is a dermatologist who is handling most of the skin cases. She came to me and she insisted that her son is also should be given HPV vaccine. I explained her and gave the vaccine.
Absolutely.
Right.
That's a good experience. Sir, about the adolescent girls having taken HPV vaccine, is there anything related as GBS, Guillain-Barré syndrome, myelitis, anything to be worried
All those
about?
are extremely rare. Extremely rare.
Does it
no
happen?
correlation
Is there
established. There is no causal
any evidence for
correlation
that?
established between the GB syndrome or any other complication.
See, whenever you have an adverse effect, you have a temporal relationship and a causal relationship. So if following a temporal relationship, there are established criteria to establish causality. When these have been applied, no causal relationship has been proven as far as HPV vaccines and GB syndrome, venous thromboembolitis, even chronic pain syndrome, or even postural orthostatic stop, nothing. So I think it is a safe vaccine.
What about the recommendation for MMR in an adult by CDC guideline? Anything like specific?
They say if
MMR in
you've
an
been born before
Two doses,
1957, if you're born before 1957, you don't need it. But CDC says if you're born after 1957, you can take the vaccine if there is no documentary proof.
You have discussed about COVID and MMR. You said COVID and BCG. What about COVID and flu vaccine?
I knew this was coming.
Dr. Meera has posed this.
Same. Flu is also an RNA vaccine. Influenza is an RNA virus, negative stranded, and COVID is an RNA virus, positive stranded. So there is some kind of cross protection, but you can't give flu vaccine to protect against COVID.
Positive and negative will attract each other.
So maybe COVID will be more that way.
No. See, there was some fear that influenza vaccine may increase the incidence of COVID, but no such studies have demonstrated it's been a theoretical risk. And at the same time, co-infection is very uncommon as far as COVID is concerned, along with influenza. So I think you give influenza for protecting against influenza, and that has nothing to do with COVID.
What about the
Sir, please.
Recently published Brazil paper which shows that hospitalization and serious infections of the COVID are less in influenza
vaccinated. Okay.
Sir, for a query from my side, what about the dose of quadrivalent this flu vaccine below 3 years? Is it 0.25 ml or 0.5 ml?
Depends on which vaccine you are using. Depends on vaccine which you are using.
Fine. Then the parents are confused. That one parent said his elder child was given 0.25 ml. Now you said 0.5 ml.
Okay.
Is it okay,
now,
sir?
I think one message let us get across. This is a brand specific recommendation.
Absolutely.
In our country, DCGI has approved it only for the Influvac Tetra and not for the flu quadri. They have applied for it, but they have still not got it. Even in USA, it is not for all the brands. Only 2 brands are acquired. I don't know them. I don't want to confuse by telling the names, but it is a brand specific recommendation and not a uniform recommendation as of now.
So my concern is here, as a practitioner, my parent is confused that because the volume, they matters a lot, 0.25 and 0.5 ml. So for them, the brand is always fine. One brand or other brand, it happens many a time. But volume, they say that's a double the dose. Is it okay? Are you going wrong? Whether our academy is going, they are still confused.
No, we are not going wrong. There are advantages. One is reactogenicity is equal whether you give 0.25 or 0.5 ml. So adverse effects is gone. Immunogenicity is more, especially in children between 6 and 12 months of age. May not make much difference in those who are 12 to 24 months. Antibody titers are definitely statistically significantly superior, especially against the B strain and not against the H1N1 or the H3N2. So I think all in all, it's a good idea to have a uniform recommendation. The volume, see, between 0.25 and 0.5 in a 6-month-old child really doesn't make much of it. Everything is the same.
Logistically,
fine, sir. It's very difficult to impress upon a Googling parent. This one, I have experienced it twice, I think. Anyway, fine, sir. I believe. Any other comments, sir?
No, that's it. That's it.
So I believe we have covered a good number of questions, 18-20 questions from the floor, and not many discussions were there. And I'm happy that I'm seeing a lot of our seniors, learned pediatricians, my good friends, IAP, our past executive board members, past presidents, even national presidents are on the platform. And it's quite an enticing time for absorbing time, 2 hours, and little more than 2 hours, I believe. You have been on, Shashi sir would have been literally, I think you are used to master long innings you have been used to many a time. 2 hours literally exhausting, but my panelists are also very active. I'm so little sad that Dr. Sanjay Niranjan couldn't log in because he had some problems, technical snacks right from the beginning. and I believe he can join us for some time later in some other session. We would like to learn from him also. But it was so good of you. All the panelists and experts have been so, I think, so dynamic and so fast-paced and very crisp in their, especially regarding that rabies vaccine, the BCG, and many things, and even the vaccine expiry. Many things you have brought out to our notice, which would have been quite confusing in our day-to-day situations. So thank you so much from my side, our moderator Kashi sir, as well as Dr. Arun Bathwa, Dr. Surendranath, as well as Dr. Sanjay Marathe and Dr. Sanjay Niranjan for being with us and giving us an entertaining academic learning experience with the vaccines and with the
also thanks to Dr. Sunil Kumar Agarwal. He was answering chat questions immediately.
Yes, many of the questions I didn't mention.
Time for us. He has already answered half of
He has done most of the job.
Because I didn't mention.
Thank you, Sunil.
He had done a wonderful job in the platform. He has come down, reduced Kashi sir's load a lot with the QA session.
I have not seen a more enthusiastic person than Dr. Sunil Agarwal.
He is so vibrant and dynamic, and any platform he is there, and he is there up to date, on the move, always on the toes. But he was there, and it's now time for my president and secretary of the organizers who are around, Dr. Balachandar, Dr. Narayan, Krishna Mohan, and others.
Yes.
And thank you so much for the participants for the very interesting discussions, as well as being with us for more than 250, 260, 270 members of our family IAP fraternity were there with us for today for all through the 2 hours session. So thank you so much.
Thank you.
Dr. Bala.
Yes.
Thank you.
Thank you very much.
Our president, Dr. Balachandran, Narayan.
They're all gone.
No,
Hello.
sir, they are here till now. Dr. Ranjit, you can
Hello.
take up. But
Dr. Ramesh, what are the blue violet color lights on your spectacles, round? Are you using a TikTok illuminator?
Nothing, sir. This is simple. You can see it's only a reflection.
Not the Geo one, na? The Geo has come with something new, na?
Anti-glare coating is.
Yes, there are some lights around. Some lights are there from both sides. Dr. Arunji, lights are there from both sides. I think it's getting.
These are the lights he's put up, those circular lights, illuminated lights.
Yes. Exactly.
They're called the TikTok lights. TikTok lights.
TikTok lights, exactly.
Yes.
TikTok.
Yeah.
Amazon. It comes from Amazon.
Yeah. No, even I've got it, so I know. I'm not using it just now.
Okay, fine. Ranjit,
Thank you, sir. Thank you very much.
Thank you, sir. Thank you, Kashi sir.
Website editor and he's a technical host.
Thank
Ranjit.
you.
On behalf of IAP Kerala, Ranjit, please.
Thank you, Kashi sir, and all other panelists for the exciting discussion, which lasted for about 2 hours, and still we are eager to know more from you. And thank you, dear Ramesh sir, for moderating and chairing the session so wonderfully. Thank you all the participants, all the members from all over the country who joined the meeting. Thank you, sir. Have a good day. Good night.
Thank you.
Thank you,
Yes, sir.
Thank
We
you.
had a lot of appreciative remarks in the platform, and even
Thank
personal messages already dropped in for me for arranging such a great panel. All of you deserve and all that from our side. Thank you so much.
Thank you.
Thank you, Dr. Ramesh.
Thank you.
Thank you, sir. Thank you, Kashi sir.
Thank you,
Thank
sir.
you.
Sanjay
Dr.
Marathe.
Thank
Both
you, sir.
Dr.
Thank you,
Ramesh.
Dr. Ramesh.
Dr. Ramesh, thank you.
Thank you
Marathe had a white and a red tie that looks so
Dr.
awesome.
Sanjay Marathe is always prim and proper, always.
He is the director, Colors Hospital. He cannot be such a big institute. So it's so good. See, at least you are there under formal suits. Thank you.
sir.
Thanks. Good night, sir.
Thank you. Good night.
Thank you,
Good
sir.
night.
Bye bye.
Have a great good night.
Thank you. Good night.